Myxomatous mitral valve disease and congestive heart failure in a dog, a case created by Jake Johnson. Meet Bo, an 11-year-old intact male Shih Tzu who presented to the Tufts Emergency Service for increased respiratory rate and effort. Bo had a prior diagnosis of myxomatous mitral valve disease and congestive heart failure. Previous therapies included pimobendan, enalapril, furosemide, and spironolactone. Prior echocardiographic exams had confirmed a diagnosis of mitral valve disease with a thickened mitral valve and marked enlargement of the left atrium, as shown here. Pulmonary edema was previously noted on thoracic radiographs. Bo was previously diagnosed with stage C heart failure. Over time, despite escalation of drug doses for these 4 cardiac medications, Bo had recurrence of clinical signs, and he returned to the emergency room for an episode of increased respiratory rate and effort, as well as collapse while on his morning walk. On presentation, he was tachypnic and orthopnic, with his head and neck extended outwards and his forelimbs abducted to help facilitate breathing. A 5 out of 6 systolic murmur was noted with the point of maximal intensity on the left side of the chest over the mitral valve. Given his degree of respiratory distress, Bo was placed in an oxygen cage. Numerous B lines were noted in multiple lung lobe regions on point-of-care ultrasound exam. Continuous ECG monitoring by telemetry was performed to search for any arrhythmia that might have caused collapse. His telemetry showed an underlying sinus rhythm with frequent ventricular and atrial premature contractions. The blue arrow points to where a supraventricular premature depolarization is followed by a ventricular premature depolarization. Initial blood work revealed leukocytosis, possibly consistent with a stress leukogram, as there were no band neutrophils or toxic changes to the neutrophils. On serum biochemistry analysis, Bo had mildly elevated BUN and a normal creatinine. 2 of the liver enzymes, ALT and ALP, were mildly elevated. The potassium was normal, and the only electrolyte abnormality noted was mild hypochloremia, likely related to prior diuretic use. Following initial supplemental oxygen therapy and 3 intravenous doses of furosemide, Bo had thoracic radiographs obtained, which revealed moderate to severe cardiomegaly with a vertebral heart size of 12 vertebrae. There was dorsal displacement of the trachea due to cardiac enlargement, and the caudal mainstem bronchi were compressed by the left atrium. The pulmonary veins were mildly distended. There was an alveolar pattern in the parahilar region as well as several other lung lobes, and this is especially notable in the right caudal lung lobe on the dorsal ventral view. These findings are compatible with cardiogenic pulmonary edema. Moderate hepatomegaly was also present. Based on these clinical and radiographic findings, Bo was deemed to have active severe congestive heart failure. To reduce his pulmonary edema and help alleviate his respiratory distress, Bo was administered intravenous boluses of furosemide, a loop diuretic, with a cumulative dose of 10 mg per kilogram over 6 hours. Bo's respiratory distress was only minimally improved despite this treatment, and a continuous rate infusion of furosemide was initiated. Sodium nitroprusside, an arterial and venous vasodilator, was also added to his treatment regimen. Following administration of sodium nitroprusside via continuous rate infusion, Bo's respiratory rate and effort were significantly improved, and he was able to rest more comfortably in the oxygen chamber. In addition to his furosemide and sodium nitroprusside continuous rate infusions, Bo received oral doses of spironolactone, enalapril, and an increased dose of pimobendan. The following day, laboratory testing showed stable kidney and liver values, but decreases in sodium, chloride, and potassium. An oral potassium supplement was added to Bo's treatment regimen. His telemetry showed mostly sinus rhythm with infrequent atrial premature depolarizations, which were not specifically treated. A specific arrhythmic cause for the collapse was never identified, and the collapse was suspected to be due to severe congestive heart failure and reduced cardiac output. Bo continued to recover, and his appetite returned to normal as his respiratory rate and effort steadily improved. A more complete echocardiogram was repeated once Bo could spend some time outside of the oxygen cage. The right parasternal short-axis view showed a dilated left ventricle in diastole and a volume overload to the left ventricle with hyperdynamic contractile function. The right parasternal long-axis view showed significant mitral regurgitation, noted as the green multicolored blush headed back into the left atrium, as well as thickening of the anterior mitral leaflet. Moderate pulmonary hypertension and tricuspid regurgitation were present, along with fewer B lines than were noted on the original point-of-care ultrasound exam. These echocardiographic findings are relatively typical for a dog with myxomatous mitral valve disease and congestive heart failure. Repeat radiographs showed stable cardiomegaly, significantly improved pulmonary infiltrates, and resolving pulmonary edema. This is consistent with his good clinical response to treatment of congestive heart failure. Following Bo's fourth night in the hospital, where he rested comfortably overnight, he was able to breathe with minimal effort, and he underwent an oxygen trial, which he tolerated well. In order to transition Bo from an in-hospital to an out-of-hospital setting, all of Bo's IV medications were discontinued. He was started on oral sildenafil to treat his pulmonary hypertension. Follow-up chemistry analysis showed a persistent elevation of BUN, normalization of liver values, and ongoing electrolyte derangements, likely caused by aggressive diuretic therapies. Given Bo's overall clinical improvement, lack of requirement for supplemental oxygen, stable blood work, and improved radiographic patterns, he was now ready to go home. In comparison to his original medication regimen on arrival, Bo was discharged from the hospital with increased doses of furosemide, pimobendan, and spironolactone, while maintaining the same dose of enalapril. Torsemide, sildenafil, and a potassium supplement were added to his treatment regimen. Bo was scheduled for a recheck in 1 week after hospital discharge for repeat blood work and a repeat examination to make sure he's tolerating his medications and the heart failure was still controlled. 5 months later, Bo is still doing well.